Glaucoma is a chronic progressive disease which until the very end is mostly without any symptom. And it's very hard for the patients to understand the reason for the therapy. And considering that traditionally the medical therapy is the first step in the treatment of glaucoma, it's very difficult for the patient to accept the local and the systemic side effects, to accept the strict regimen, the difficulties in using the drops, and mostly the feeling of a never-ending therapy. These are all well-known barriers to the use of medical therapy in glaucoma, which at the very end lead to a very poor adherence. And even worse, in some cases the patients are really rejecting the disease, and so they are just disappearing, which is terrible for the outcome of the visual function. It really depends on how you are explaining the pros and cons of medical therapy and the pros and cons of SLT. So when I'm starting a patient on therapy, I'm always explaining him that there is a possibility to use a laser to lower intraocular pressure by rejuvenating the physiological outflow pathway instead of using drops. And generally, considering the side effects that drops can provide to the patient, they are mostly willing to start with a laser. I'm also explaining that the worst case scenario with the laser is the lack of efficacy, which can happen easily also with drops and without significant clinical consequences. Yes, definitely. SLT can replace one or more medical therapies. And as a matter of fact, I'm using SLT not only as a primary therapy, but when a patient needs more drugs to have his pressure controlled. Let's say when the patient needs more than one fixed combination, I'm generally proposing SLT. Another clinical case where SLT is really useful is when there is intolerance to one drop, and if this happens, you can easily change the intolerant drug with SLT, with great benefit for the patient in terms of quality of life. Well, one of the most significant benefits for SLT is that the control of the disease is not in the hands of the patient, but goes back in the hands of the ophthalmologist, as it should be. Certainly, this is very important, but on the other hand, we have to consider a drawback for that. When the patient is using drops every day, every single time he's putting the drops in his eyes, he's remembering that he has glaucoma. And when we are using SLT, the risk is that the patient can feel that the laser is a cure for the disease and then forget to go back to the office to do all his functional and structural examination, and which is very, very, very risky. So it's very important for ophthalmology to be very clear so that the patient is going to understand perfectly what is the meaning of SLT and what is its role in the management of glaucoma. Another benefit is definitely the lack of systemic and local side effect, which is certainly not affecting the quality of life of patient and increasing the adherence that the patient have. Finally, SLT is working 24 hours a day, 7 days a week, and is very stable, and it can really flattening the diurnal curves of our patient, which is another big issue. Well, I'm using SLT in many different ways. Certainly as a primary therapy, as adjunctive therapy, as replacement therapy, and also after glaucoma surgery when the target IOP is not reached. As primary therapy, I think this is the most critical issue. The big advantage of SLT is that it's effective in lowering intraocular pressure without substantial side effects. It's interesting to see that at least in Europe, there is a lot of emphasis about the side effects of benzalkonium chloride, which we know is toxic for the ocular surface. And so companies, pharmaceutical companies, are really pushing very hard toward back-free compounds used once a day to increase to less affect the quality of life of the patient. But it's interesting to see that ophthalmology should always keep in mind that SLT is totally back-free. free, it has no regimen, so in terms of quality of life is definitely far better than whatever drug. I'm also using SLT as adjunctive therapy, and generally when a patient is not controlled with one fixed combination, I better like to go toward SLT instead of adding other drugs, because it decreases the risk of side effects, and certainly it decreases the risk of being non-adherent on the side of the patients. And finally, especially recently during the past 10 years, we are facing more and more intolerance to drugs. And when this happens, beside how this is affecting quality of life of our patient, there is the big risk that the patient are not adherent anymore to their therapy. So when this happens, just replace the drug with SLT is always very important if we really want to manage in a good way our patient. Finally, after trabeculectomy, after glaucoma surgery, if we are not getting to the target IOP, you can easily add SLT and it works very well.